In this lecture, I'm going to be talking about disorders of bilirubin metabolism. In order to simplify this discussion, I have divided the process of bilirubin metabolism into 4 different steps. Step 1 is the breakdown of red blood cells to generate bilirubin. Step 2 is the transportation of bilirubin into the liver. Step 3 is the conjugation of bilirubin within the liver, while step 4 is the excretion of conjugated bilirubin into the gastrointestinal tract. We are going to be looking at what could go wrong in each of the steps and how the abnormalities can be identified on the laboratory results of a liver function test. Generally, disorders of bilirubin metabolism manifest as hyperbilirubinemia, which could be prehepatic if it occurs at step 1 and step 2, intrahepatic if it occurs at step 3, and posthepatic if it occurs at step 4. Step 1 and step 2 are also involved in unconjugated hyperbilirubinemia because at this level the bilirubin has not yet been conjugated, while step 3 and step 4 are mostly described as conjugated hyperbilirubinemia because at this level the bilirubin has been conjugated by the liver. In step 1, there could be an abnormal increase in the breakdown of red blood cell due to hemolysis, certain type of drugs, toxin, viral infections, membranopathies like sickle cell anemia, and hereditary spherocytosis. All of this will cause an increase in the breakdown of red blood cell, leading to the generation of a high level of bilirubin, which will increase the bilirubin load being transported into the liver for conjugation. A large amount of conjugated bilirubin in the GIT will mean that a large amount of urobilinogen will be formed and a large amount of urobilinogen will be found in the urine. Essentially, abnormality in step 1 will cause hyperbilirubinemia, which is mostly unconjugated, and a high level of urobilinogen in the urine of the affected patients. There could also be an elevation in the level of AST and not the ALT, because AST can also be produced by the red blood cells. So, whenever there is a discordance in the elevation of AST and ALT, in which AST is mostly elevated while ALT remains normal, it is most likely that the AST is being produced from the breakdown of red blood cell, and the liver is mostly intact at that point in time. In step 2, there could be a disruption in the transportation of bilirubin bound to albumin into the liver for conjugation. This could happen in situations where there is not enough albumin in circulation to transport bilirubin, or in situations where there are other albumin-bound molecules that displace bilirubin from albumin into circulation. In this situation, just like in step 1, there is a higher level of unconjugated hyperbilirubinemia in the blood, meaning that a higher level of bilirubin will be conjugated in the liver, and a higher level of conjugated bilirubin will be excreted into the GIT, leading to a high level of urobilinogen in the urine. So generally, in step 1 and step 2, there's usually unconjugated hyperbilirubinemia and a high level of urobilinogen in the urine. Disorders in step 3 could either be unconjugated or conjugated hyperbilirubinemia. In situations where patients have congenital deficiencies in the enzymes that are involved in bilirubin conjugation, like Gilbert syndrome and Crigler-Najjar syndrome, patients may be unable to conjugate bilirubin, leading to the accumulation of unconjugated bilirubin in the circulation. In other situations, however, the liver may be able to conjugate bilirubin, but there are other conditions that may lead to the accumulation of the conjugated bilirubin in circulation. For example, in conditions of liver injury, either by toxins, drugs, or alcohol, liver cells are destroyed by these toxins, and this leads to the release of liver enzymes into the circulation like ALT and AST in almost equal proportion. Also, in situations of viral infection, especially in hepatitis B, The virus may cause a massive destruction of liver cells, leading to a release of high level of AST and ALT in circulation. In such situations, there are high level of conjugated hyperbilirubinemia and high level of ALT and AST in almost equal proportion in the blood. So total bilirubin will be massively elevated, ALT and AST will also be massively elevated, and conjugated bilirubin will be massively elevated, much more than it is expected for the situation. Usually, because the liver is still able to conjugate bilirubin, a large amount of conjugated bilirubin is excreted into the GIT, which can lead to an elevation in the amount of urobilinogen in the urine. In step 4, which is usually a post-hepatic hyperbilirubinemia, there is usually an associated obstruction to the excretion of conjugated bilirubin in the GIT. Any kind of obstruction in the biliary tract or intestine, which may obstruct the flow of conjugated bilirubin into the gastrointestinal tract, may lead to conjugated hyperbilirubinemia. In this situation, because the conjugated bilirubin is not able to get to the gastrointestinal tract, depending on the level of obstruction, there may be a difficulty in the formation of urobilinogen and stechobilin. This group of patients may have absence of urobilinogen in their urine, and they usually do not have enough stechobilin or urobilin to color their stool, and they may present with pale stools. In addition, this obstruction will prevent the flow of conjugated bilirubin in the forward direction and lead to a situation where there is a backflow of conjugated bilirubin into the blood. At this point, because the bilirubin is conjugated and is now water soluble, it may be filtered at the glomerular basement membrane into the urine and be detected in the urine as positive bilirubin during urinalysis. So the presence of bilirubin in the urine is an indication that there is an ongoing obstruction to the flow of conjugated bilirubin in the gastrointestinal tract. So post-hepatic hyperbilirubinemia usually presents with high level of bilirubin, high level of conjugated bilirubin, and the presence of bilirubin in the urine of the affected patient.